next speaker is Kelly McQueen. Kelly is a professor of anesthesiology and director of global health development at Vanderbilt University Medical Center in the United States. She was awarded the Nicholas Green Outstanding Humanitarian Contribution Award last October during the ASA meeting. And she was awarded this for almost 3 decades of work, of volunteer work in the poorest countries, where she did a lot, I think, with a big focus on teaching anesthesia to local doctors and local nurses. Am I okay? Am I right?
Yes.
Yes. And we're going to hear what you're going to tell us.
Well, thank you very much for that kind introduction, and thanks so much for having me here. I'm always happy to be back in Amsterdam. And a lot of what I'm going to refer to, I'll go very quickly by because you've already heard it from other authors today. But Sandra specifically asked me to tie in now the Sustainable Development Goals with maternal mortality, and specifically to talk about the anesthesia gap and why that's contributing significantly to MMR in many places around the world. So I don't have any disclosures. And what I would like to cover then is where maternal mortality currently fits in with the SDGs and what the connection to mortality currently is to surgical care and anesthesia access. And then I'll give you a little bit of background that may be new to some of you on the global surgical crisis and how that relates to MMR, especially in low-income countries. And then finally, to tie that back to all of us that live in high-income countries, what can we learn from this process that's ongoing for low-income countries about our own maternal mortality rates? This is always a favorite slide. You guys have seen it several times today. This is pictures from 2013. We saw it earlier from 2015. And of course, this is where maternal mortality was at the end of the Millennium Development Goals. So things had improved significantly since the Millennium Development Goals were put in place, but still really leave a lot of work to be done to bring maternal mortality down closer to zero, where we'd like to see it. And so currently, here's the state of affairs. You can read these numbers, but to highlight a few of them, there's over 200 million pregnancies every year. Many of them are unplanned. Many of them are in adolescence, and many of them are in women who have no access to family planning. And that leads to about 300,000 maternal mortalities every year, but more importantly, about 30 times that rate of morbidities for women who are injured during childbirth or who have issues during the process. So low-income countries is where we still see the biggest problems related to maternal mortality, but I'll just tell you that the U.S. is really in a state of crisis with our own maternal mortality rate. And where I work at a university medical center that does about 8,000 deliveries a year, in the last 2 months, we had 4 maternal deaths, which was more than we'd had in 6 years. It was a catastrophic cascade of bad patient pathology, but also some systems issues which we've really moved on to address. So I just want us all to remember that this is still our problem, it's the world's problem, and even though we might focus on the highest numbers, in our own backyards, we're really still struggling with maternal deaths. So as a reminder, this is where we were 2000 to 2015. For those of us here, we were mainly focused on number 5, how to improve maternal health. And most of the ways that we improved it leading up to the end of these goals was by providing more prenatal care, more skilled attendants, and more attention to the mother as she came into the birth process. Where we are now, facing the Sustainable Development Goals, We know that things have improved incredibly, but now we really have to focus on the process of delivery because that's where we're finding our biggest challenges, and I hope to convince you that a majority of those 300,000 deaths every year could be improved with safe access to surgery and anesthesia. And so this is the overlap of what we're now talking about, the end of the MGD5, leaving us with 300,000 deaths per year, and the implementation now of the SDGs, which are much more broad. And of course, I forgot to bring out my little list of what 1, 3, 4, and 5 are, but I can tell you generically that those are reduction in poverty, overall general improved health, education, and concerns for women in general. And of course, we've already heard today that it's poverty, lack of education, lack of women's rights that really lead to those unplanned pregnancies, poverty, and other issues that are still playing a huge role. And so universal health coverage, which is now in the planning stages and soon to be implemented from the World Bank and from the WHO, intersects with all of these problems that we're discussing, and again, most especially with surgery related to maternal health. And so then we see the overlap of anesthesia, surgery, and maternal mortality rate. And I hope to convince you by the end of the talk that anesthesia really is the rate-limiting step. So these 3 events that occurred in 2015, some of you in the room may have been aware of them, but leading up to 2015, those of us working in this arena were very concerned that we were never really going to see surgery and anesthesia come onto the national scene with a commitment to providing surgery and anesthesia in low-income countries. But these 3 events were pivotal. Firstly, the publication of essential surgery from the World Bank, which substantiated the cost effectiveness of surgery and anesthesia for all countries. Secondly, the Lancet Commission on Global Surgery, which further outlined the cost effectiveness of surgery in general, but also how it could be implemented in cost-effective ways even in the poorest countries. And then finally, the World Health Assembly resolution on strengthening emergency and essential surgical care and anesthesia as a component of universal health coverage. And again, these were game changers, and I'll briefly breeze over what they showed, but we'll be happy to talk with you further about them. So DCP3, again, published by the World Bank. The whole mission of the World Bank's publications are to really look at cost effectiveness related to whatever issue they're looking at. So this publication showed that almost 30% of the disease burden could be averted or addressed with appropriate surgical care, and that 44 basic procedures, including C-section, should be provided at every district hospital. So that was a huge tipping point. And then this was the big wow in 2015, that the Lancet Commission concluded that 2/3 of the world's population has no access to safe surgery or anesthesia, and that 143 million procedures need to be undertaken annually before we can really begin to catch up. Sorry. Oh, it is. That's too bad. I'm sorry. Was the last one like that too? Okay. Okay, very good. So, and this again just highlighting that in those 2 publications that C-section was highlighted as a bellwether procedure. In other words, if you can do a C-section, you probably can do those other 44 cost-effective procedures. But that if you can't do a C-section, you are also lacking basic capacity. And there's a whole lot of information published in follow-up to the Lancet Commission on Global Surgery regarding the evidence behind these procedures, and especially the evidence behind why even elective C-section should be universally and ubiquitously available. And so the metrics related to the Lancet Commission, I think, are important because they really relate to how can we make this happen in low-income countries. And so they offered 5 metrics, 4 of which I'll just describe briefly. And that is the 2-hour access to essential surgery, including C-sections. And that 2-hour window is not 2 hours by car. That's any 2-hour window. So if you're in sub-Saharan Africa and if you have to walk to your clinic, then that's the 2-hour access. If it's on a bicycle, that's the 2-hour access. So this was very specifically delineating that healthcare centers that can provide these procedures have to be very close to the patients. Secondly, that the SAO, the surgery, anesthesia, obstetric density needs to increase to at least 20 per 100,000. And right now, as you saw from the talk on Nepal and other countries today, that it's at least only 1 per 100,000, and in many cases in sub-Saharan Africa, you might see only 1 anesthesiologist per million population. Then that surgical volume really needed to increase. And surgical volume usually isn't measured by procedure like this ratio suggests, but the Lancet Commission decided that this was the best way to look at internal capacity. And then lastly, I'm not going to discuss the financial protection issues, but perioperative mortality rate, which depending on what country you come from, is probably at least measured at your hospital. It may be shared with your government, it may not be, but that perioperative mortality rate can loosely be used as an indicator of quality of surgery and anesthesia, and as it regards anesthesia, probably an indicator of patient safety in that first 24-hour period. So back to the most common causes of maternal mortality around the world: obstructed labor, hemorrhage, eclampsia, infection, and abortion. All of these have a relationship to access to surgery. And so it's hypothesized again that those 300,000 maternal deaths that we see now, at least 75% of them could be addressed with access to surgery and safe anesthesia. So we've already talked a lot about that limit or the ratio of C-sections to live births that seems to be best. The World Health Organization reports that it should be 10 to 15%, and what we know is that when the C-section rate is less than 10%, maternal mortality is much higher, and that, as we heard about Brazil, and certainly about the US as well, when it's higher than 15%, in the US it's about 40%, we also see higher maternal mortality deaths related sometimes to the complications of surgery, but often just related to the complications of the comorbidities of the patients. So this, again, another reflection of C-section rate and maternal mortality rate. I'm going to have to add Brazil to this slide in the future. And then the recommended rates, which for most countries, most low-income countries, which would include about 50 countries worldwide, we just don't see a high enough C-section rate. And this was a paper from a few years back just substantiating that, comparing C-section rates then with maternal mortality rates, and showing that all of these countries that had very high maternal mortality rates were for the most part well below that 10% level. So the problem with lack of access to anesthesia is often related to those metrics of the Lancet Commission. Where are people located? What are the transportation issues? And where is the closest center by which they could get a C-section? Secondarily then are the resources that are required for C-section, and anesthesia. And I highlight anesthesia here because really that is the rate-limiting step. And I'll talk a little bit further about that in just a minute here, but without access to safe, quality anesthesia, it often doesn't matter if you can get a C-section, and often it's the reason that women can't get a C-section. Affordability and acceptance are two issues which will probably always be out there, but again, focusing for the moment on access to surgery and anesthesia, they're definitely the rate-limiting steps. So in these same countries, we have huge problems with overall anesthesia and patient safety. And again, that anesthesia as a specialty, not just the providers, but the lack of resources related to anesthesia are often related to unexpected and preventable deaths, including maternal deaths. I won't delve further into the pulse oximetry issues, but we can certainly talk more about that later if you'd like to. So again, my mantra, anesthesia just is the rate-limiting step for access to C-sections, and even in our own countries and cultures, anesthesia is often the rate-limiting step for quality surgery and for good patient outcomes. And we know that from our own history since the 1950s that as anesthesia provision and anesthesia capacity has improved, so have surgical outcomes and patient outcomes. It's not a one-to-one relationship, of course, but we know that without anesthesia, those same improvements would not have occurred. So 24 hours, 7 days a week, access to safe anesthesia is now the goal at the first referral hospital, which used to be called the district hospital. Those are the hospitals at which the focus is for those 44 basic procedures, including C-sections, to be available 24 hours a day. And currently in the lowest income countries, at these first referral hospitals, they usually don't have an anesthesiologist, they may not have an anesthesia provider, and if they do have either of those, they usually don't work at night. So scaling up to C-sections is the same as scaling up to surgery. Those same metrics could be utilized in low-income countries to benchmark where they are today and where they're headed. Training providers is certainly a rate-limiting step as well, or potentially a first focus, a lot of people would argue, but without essential medicines and safety monitoring, the cascade of problems will still exist. And so everything needs to be done in combination, training providers, making sure they have access to the medicines and monitoring they need to provide safe care. And so bringing it back around then to high-income countries, again, we are still struggling with these same issues, although our patients' pathology certainly is contributing to a greater degree. We have increasing comorbidities in my state, where we have one of the highest rates of opioid overdose in the U.S. Probably 50% of our parturients are addicted to opioids, causing yet another complication in that population. But then obesity, our own high C-section rates, and sometimes our poor preoperative management, back to the point of this morning, based on communication between anesthesia and surgery, still exists as well. One new comment to just throw into the mix for your thinking is, would enhanced recovery after surgery be appropriate for obstetrics? I think the ERAS community already believes that it will be very appropriate for obstetrics, and it may prove to be a very helpful platform in high-income countries and low-income countries to really bring the two communities together to talk about patients, to plan for protocols, and to follow outcomes. So I think, as we've already pointed out, it's a mere 13 years until 2030. That seemed like a long time when we started out 3 years ago in 2015, but the clock is ticking and we have a whole lot of work still to be done. So thank you very much.
Thank you very much, Kelly. Can we wait for a question? I know we're limited on time. We are limited on time, but I think we can have one question. One question, or we're just moving on.
Okay.
And people can ask questions later on. It was very interesting to hear your talk, and I think there's a lot of work for us to do in helping you train anesthetists and anesthesia providers and a lot of other things. Thank you.